So today we'll be talking about COPD exacerbations and CHF exacerbations. Acute COPD is a gas exchange problem. COPD stands for chronic obstructive pulmonary disease. Chronic bronchitis you'll see as one, you'll see a larger patient with that. Emphysema, a skinnier patient. You'll see the parameters is 88 to 92 because the doctors would order it that way. So COPD is a chronic lung inflammation. Obstructing airflow to the lungs, basically having repeat injury to the lung tissue. You'll see hypersecretion of mucus and obstructed ventilation. So mucus will stop the ventilation from happening properly. You'll see cytokine release just for inflammation. Basically, it's due to long-term exposure to irritants, and macrophages help to attack and clear these irritants. Some irritants would be cigarettes, pollution, smoke, dust, chemicals. And genetic-wise, you'll see an alpha-1 antitrypsin protein deficiency. So basically, these are immune cells, like basically as white blood cells, and they'll destroy your own lung elastic fibers, reducing lung elasticity and recoil. So you're not going to have too good ventilation. And usually having higher, this would affect your CO2 accumulation inside of your body. Therefore, alveoli become floppy and the bronchioles and airways collapse on itself before exhalation is complete, which is going to be atelectasis. So this one can lead to atelectasis. It's basically having the less amount of AAT causes the lung elasticity to be low and a lot more scar tissue to be formed, causing exhaled air to be trapped. That's why you'll see pursed lip breathing with these patients. Normally alpha-1 antitrypsin protein helps protect the lungs from any macrophages, which is the one that are meant to kill these irritants that we talked about. But if you don't have enough in the first place, you technically are not going to be able to protect your lungs, and so you'll have macrophages actually attacking lung tissue, causing more inflammation, more hypersecretion, and more of an obstruction to your airway. Cold temperature also affects COPD, and having asthma, apparently being a female, and recurrent infections because of the inflammatory process. Signs and symptoms you'll see are like shortness of breath, so difficulty breathing, tachypnea, so high heart rate. You'll see shortness of breath on exertion a lot, and like I said, pursed lip breathing. You'll see a chronic cough with or without mucus. And if they have mucus, it's an obstruction like we mentioned. You'll see wheezing for the pursed lip breathing because all the trapped air inside of the body is trying to get out, but it's not able to. So you'll see chest tightness, accessory muscle use sometimes. You'll see a bunch of respiratory infections like pneumonia because you're trapping air, you're trapping bacteria, you're trapping irritants. Fatigue because you're so tired of having to work so hard to breathe, and also you're not being able to exchange CO2 and oxygen properly, so it will cause less oxygen to the brain. Basically, fatigue is another name of saying cachexia, increases your fall risk because you're basically lightheaded too, right? Cyanosis, so I don't know. You'll see cyanosis for sure in the lips, in the nails, if the oxygenation is not well. Increased oxygen demands from cyanosis, obviously, because you're not getting oxygen. You're going to see a lot of ventilation problems, so low elastic recoil of lung tissue, low gas exchange, so gas exchange is not well. You're going to see lungs collapse, alveolar collapse, mucus plugs, preventing the alveolar diffusion distance, so it's going to be harder for you to actually feel like, because of the mucus is coming in the way, you're going to feel like you're a harder time to actually perfuse oxygen because your oxygen is not being able to go past the diffusion membrane. So the more COPD exacerbations you have, the more disease progression it shows. So if you're coming in the hospital all the time for COPD exacerbations, that shows that your disease is kind of on the brink of being the worst. COPD exacerbations can also happen if you're not adhering to medications. Patients have right ventricular hypertrophy because the lungs are not being perfused well, so that causes backup into your right side of your heart. You'll see large pulmonary arteries as a way to compensate, to vasodilate a lot, to actually increase the blood flow, but it doesn't really help as much as it should. There's a high risk of blood clots secondary to immobility with people like this because it's very encouraged to have bed rest, but because of so much bed rest, then you'll have immobility, causing the DVTs. Polysthemia, so many red blood cells, is another risk. Dehydration is a risk of COPD exacerbations because you're losing a lot of insensible fluid, as well as not able to retain as much fluid or drink as much because you're so exhausted or you don't have enough energy to drink or eat. COPD exacerbations lead to hypoxemia, which is basically low oxygen circulation in the blood, with or without hypercapnia, which is a lot of CO2 in the blood. Severe cases, basically when it gets to the worst of the worst, you'll see low blood pressure, you'll see the flapping tremor because of the oxygenation not getting to the body, as well as CO2 is built up and causing asterixis here. You'll see mental status changes, obviously decreased LOC. You'll see not alert, not oriented as much. You'll see peripheral edema because there's going to be basically left-sided, if the lung is being affected, you're having left-sided failure. So yeah, left-sided failure causes lung problems, but it will cause peripheral edema and pulmonary edema. You're going to see paradoxical chest wall. So basically, when you're supposed to have inhaled, your chest will actually show like it's going in rather than out. So basically, you'll see opposite movement of chest wall with inhalation and exhalation. Your diagnosis will show through a chest x-ray, a CT scan of the chest, I believe, or the abdomen, really. Spirometry test. Apparently you're not supposed to be doing this during exacerbations though, but apparently you can do it to find out what the hell is going on. ABGs, you're basically helping to measure oxygen, partial carbon dioxide, blood levels. You'll most likely in this situation see a lot more carbon dioxide in the blood than oxygen. You're going to see VQ mismatch, so alveolar ventilation is a ventilation part. Q is a pulmonary capillary perfusion, so if it's not working out with the alveoli, then it should be a 1-to-1 ratio. But it's going to be a mismatch. You'll also see vital capacity here as a total amount of air exhaled after breathing into the max. So as soon as you inhale, it's the same amount that should be exhaled, but because inhalation is so much but exhalation is not, that will be it impacts ventilation a lot for COPD people. Another thing to mention is COPD can cause arrhythmia. Because of the pulmonary hypertension, you're going to see right-sided heart failure and you'll see afterload increase because of that. You'll see sometimes right ventricular hypertrophy like we talked about here. Yeah, it's very important to know. Some things to know for meds for COPD is that they're more frequently used for exacerbations, so meter dose inhalers are recommended to be used more. You'll see bronchodilators, which are beta-2 agonists. So basically the beta-2 that works on the heart and the lungs basically helps to vasodilate. And there is a risk of hypokalemia with this one because of so much dilation. You'll see bronchodilator as salbutamol. Salbutamol is also known as Ventolin or albuterol. And you're meant to be using salbutamol way before you would even think to use ipratropium or corticosteroids or nebulizers, or prednisone basically, because it helps to open the airway before the actual corticosteroid and anticholinergics can actually take effect. Ipratropium is a cell. Basically, when you see salbutamol, think about O as in bronchodilator. Ipratropium and corticosteroids like prednisone, they're steroids, so they're short acting. This one is short acting and anticholinergic. Problem with this one is also called Atrovent. So think about vents, and it helps with relaxation. When you see Atrovent, think about vent, and it helps to relax so you can ventilate. Salbutamol, you think about you think about bronchodilation. It's a short-acting anticholinergic, dry mouth, urine retention, and constipation. So it's very important to see these things, which they can cause eventually maybe delirium. But also urine retention causes more problems with CKD patients as well, so be careful. Also will even more cause problems if you're retaining more fluid to the lungs as well, because it can cause backup into the heart, and the heart will have a more afterload, more preload, more workload basically to perfuse, and can potentially lead to pleural effusions. Corticosteroids, they're really helpful. An example of it would be prednisone, but it lowers inflammation, but also it does the same thing that we talked about, increases fluid retention. So if someone has heart failure or CKD, this is a problem. Corticosteroids, the problem with this can be hyperglycemia, because you're not able to, it's basically effing up your immune system a little to actually get to the problem of things, and muscle atrophy, osteoporosis. When someone is noticing purulent sputum, it's very important to treat them with antibiotics eventually, because you want them to obviously have the infection cleared. You can also use statins, apparently. Not really 100% sure how this is going to help, but it's a part of it. Another thing really important are NACs, which are N-acetylcysteine. It's a mucolytic, basically. Mucolytic specifically to help thin and loosen thick mucus in lungs, so basically clear the obstruction from mucus. And then also for the liver, if someone had a Tylenol overdose or any kind of toxicity, it's an antioxidant, so it helps really, really well. Only thing is, it doesn't really taste good, but I'm not sure how much we need to know about that. Interventions like we talked about, bronchodilators, the salbutamol, the albuterol, Ventolin. You can see that it improves airflow, obstruction, and reduces lung volume. Short course oral steroids, basically, what was I saying here? Yeah, any prednisones, they reduce pulmonary inflammation, reduce the risk of relapse. Antibiotics are helpful for bacterial infections and sputum that's purulent. Mechanical ventilation only if you have unstable hemodynamics, impaired mental status, or a massive aspiration. So when you have a sputum culture and gram strain, you can also figure out what kind of antibiotics to be giving. ABGs, diagnosed respiratory failure. So we talked about the partial oxygen, partial carbon dioxide. Make sure always check the pulse oximetry. Obviously, we need to know that. ABG measurements, electrolytes, very important because potentially fluid retention, like we mentioned, of the side effects. Polysthemia, because acid-base imbalances. Polysthemia, so a lot of red blood cells, because it's maybe a metabolic disorder. BNP, so brain natriuretic peptide, that is released when the heart feels like it's working hella hard to have a lot of preload. So if a lot of stretching of the heart, BNP gets released, and that means that could lead to what we talked about with heart failure. So you'll see pitting ankle edema, you'll see dyspnea and resolve with COPD exaspiration treatment. Basically, if you see BNP, it differentiates congestive heart failure from COPD. You'll see elevated jugular venous pressure because it's a heart failure thing. So BNP, heart failure. Heart failure and COPD are easily confused because of a common cardinal symptoms of breathlessness. You'll see a D-dimer for clots if you see a pulmonary embolism. Chest radiograph, basically to see Chest discomfort not responsive to exacerbation treatment. You'll see cardiac enzymes, ECG to see the rhythm if COPD causes right ventricular hypertrophy, which causes jugular vein distension. That's that. And then we'll talk a little bit about gas exchange. So gas exchange is a process of oxygen transported to the cell and carbon dioxide transported away from the cell. It happens in alveoli and tissue, so you get oxygen and carbon dioxide exchange through the blood. Basically, pneumonia, COPD exacerbations, and pleural space disorders cause problems for this. Now we'll see gas exchange. So you'll see optimal, which is obviously what we want. Impaired is hypoxia, and none is anoxia. Anoxia is the worst, obviously, because it's without a gas exchange. And you'll see anaerobic metabolism. Patients will compensate a lot. You'll only look at the state of the blood to determine these. Hypoxia is when the tissue isn't getting it. Hypoxemia is when the blood is not having enough. So you'll see oxygen is needed for cells to metabolize energy for aerobic metabolism. So it's very important to have oxygen in our body. If you're not getting enough oxygen in your tissue, you'll see hypoxic cell injury, hypoxemia, basically the state of the blood, right? When the blood is not getting enough oxygen, hypoxia is a state of tissue. Hypercapnia is when carbon dioxide buildup and not able to be expelled. You'll see the body compensate a lot. You see increased work of breathing. You'll see anxiety from patients. Anxiety could be also an additive effect because of your oxygenation not being perfused well to the brain. Affects the control of ventilation. You'll see hypoxemia again in the blood, and that is the one that leads to hypoxia in the tissue. But hypoxia does not mean technically you have... Oops, sorry about that. But hypoxia does not technically mean you have hypoxemia. It's usually when you have hypoxemia, which leads to hypoxia. But if you have hypoxia, it doesn't necessarily mean you had hypoxemia in the get-go. Potentially it's because, let's say, a clot or something happened to the tissue itself that maybe had an infarction or something, right? Gas exchange is meant to help with gas transport, pulmonary perfusion, alveolar capillary diffusion, and ventilation. So gas transport is affected by having low red blood cells and low hemoglobin. Obviously, if you're not having enough red blood cells, then you'll have no hemoglobin to be actually attaching oxygen to. So that's a problem. So we talked about having polycythemia, but also red blood cells are hella important. Pulmonary perfusion, so blood is going to and from the lungs, affected by low central perfusion. So if you're not having that much central perfusion, your pulmonary perfusion is affected, and the blood vessel is narrowing, so your pulmonary hypertension here. Alveolar capillary diffusion, so if you have a thick ass amount of mucus, hard for that to happen. It increases diffusion distance and lowers the surface area. Ventilation is affected by not enough lung compliance. We also talked about vital capacity. It affects ventilation as well. Affected by airway obstruction, neuromuscular dysfunction. And you manage at gas exchange by making sure the infection is under control, stop the smoking, deep breathing cough, incentive spirometry, pharmacotherapy, oxygen therapy, chest physio, airway suctioning, position the person high in bed, not just semi-Fowlers, but hella high in bed. Chest tube and thoracentesis if needed, if it's a pneumothorax, or we'll talk about the thoraxes in a sec, but thoracentesis if there's air or fluid inside of the pleural cavity. Assess for patient history, any risk factors, like are they a smoker. Symptoms, you'll see cough, dyspnea, chest pain for these people, which can be confused both with CHF as well, so be careful. Vitals, obviously all the vitals. Level of consciousness can be going down. Gas exchange assessments, obviously looking for work or breathing, accessory muscle use, lung sounds and chest symmetry, appearance, skin color, cyanosis, anxiety. Look for your labs, your ABG, CBC sputum. Look for diagnostic imaging like your chest x-ray, your CT scan, your VQ scan, which is a VQ scan is alveolar ventilation, pulmonary perfusion. So the mismatch should be 1-to-1, but it won't be in 1-to-1 for COPD patients. Pulmonary function test, bronchoscopy, you'll see as well. Yeah, that's pretty much it for COPD. We can go and talk about pneumothoraxes real quick, actually. So basically, types of gas exchange problems. So if you see a pleural space disorder here, right here. So pleural space disorders can happen from many things. Let's say, for instance, cirrhosis and ascites. So third spacing causes pleural space disorder. So basically, a chest tube is inserted to clear air fluid from pleural cavity to reestablish a negative pressure, which is inside the lungs. So there's more negative with deeper inhalation inside the pleural cavity to re-expand the lungs. So basically, the whole point of a chest tube or any type of chest tube is to re-expand the lungs. Usually after 3 days, you'll see like a chest tube not having that much air bubbles or whatever, or not that much output in the chest tube unit. It's because the lungs could potentially have been expanded now and good. So make sure you do your chest assessment by listening to the lungs. It's helped to basically get into normal breathing. It could be due to either air or fluid. So let's look a little bit about what's going on here. So you see the diaphragm right here. It basically, upon inspiration and exhalation, you'll see on inhalation the diaphragm contracts and moves downwards. So basically, the more oxygen in here, the downwards it goes, and the rib cage outwards. So when oxygen goes in, everything goes down or out. And the parietal pleura moves out with it. So we'll talk about that in a sec. And then basically it pulls the visceral pleura as well with the lung too. Inhalation basically is a pressure within the lung. Basically helps to get decreased. Therefore air flows in. When pressure in the lung is low, then air flows in. Basically against the diffusion we talked about. Air flows in when interpulmonary pressure is lower than atmospheric pressure. So when it's negative inside, the more air will go in. But if it's positive inside, the less air will go in, and that'll be a problem too. So inhalation, more volume, increases the volume in lung and decreases the pressure inside. So having air inside also decreases the pressure. But if it's too much, will increase the pressure, obviously. Exhalation is when the diaphragm relaxes and the lungs naturally recoil and pull the lung inward as air flows out of the lungs. So basically, when you have exhalation, all the air goes out, and the rib cage and the lungs and the parietal pleura move in, the diaphragm moves in as well. So basically, it's back to its normal position. And then basically air flows out of the lungs. If you have less volume inside the lungs, it leads to higher pressure, like holding your breath. So if you don't have enough volume in your lungs, it leads to high pressure. And then holding your breath actually increases the pressure inside, which is not good. And that happens with the COPD patients. In the situation, you'll see the lungs right here. This is the the right lung. And so this is a thoracic cage, diaphragm, and this is in more detail. You'll see the lung is here. This is a visceral pleura. This is a pleural membrane, and this is the parietal pleura, and this is the thoracic cage. So whenever you breathe in and out, the parietal pulls the visceral with it, which pulls the lung. So parietal, visceral, pleural space. Pleural cavity is the whole damn thing. So basically, this is potential space. Pleural space, aka potential space, and it has negative pressure inside, has to be maintained. There is some fluid here that helps to stick these two together, but if there's space that was from potential space becomes a actual space, then that fluid doesn't do shit, and so these things separate, and it's going to be a problem, and it can cause lung collapse. problem when there's potential space that converts into actual space with fluid and air. Like I said, it doesn't do the whole same mechanism of pulling the parietal, pulling the visceral and the lung together, so that's a problem. Serous fluid here helps to reduce friction when lungs expand. It prevents lung collapse, helps parietal and visceral stick together, so when chest wall moves up and out, allows both two pleural to move with it, and lung is pulled with it to expand. The chest wall and diaphragm coordinated muscle. You'll see this in someone that has a pleuresis, aka pleuritis. There's so much inflammation in this area, so the more you breathe in, upon inhalation, it really hurts, but you can't really expand your lung that much here, and it actually just rubs against each other, and that's not good. Let's talk about the types. Another thing to mention, air. The tube is inserted between the second and third intercostal space, so basically the top area. You'll see this for the pneumothorax. You'll see this for tension pneumo. Tension pneumo is only mainly for, you'll do the needle first, thoracentesis, and then you put the chest tube in. You also see this for spontaneous pneumothorax, or like the people that have the blebs that kind of rupture. You'll see that for tall and skinny guys, and a COPD exasperated person will also experience spontaneous pneumothorax sometimes. When you see fluid or blood, the tube is inserted in the fourth and fifth intercostal space, so basically down. You see this for a hemothorax. You'll see this for a hydrothorax. You'll see this for a pleural effusion as well. Now, types of chest tube reasons to be put in. So if basically pleural disorders like this, pleural effusion is when they have hella fluid, basically. It happens when you have third spacing. It could be due to hella different things. It could be from CHF. It could be from basically increased hydrostatic pressure or low oncotic pressure, inflammation, basically leaky vessels, infection, again, leaky vessels. And happens secondary to pneumonia, so again, infection, leaky vessels, heart failure we talked about, because third spacing goes from the heart and it basically goes to the lungs, and the pleural edema causes third spacing, so it goes fluid into the pleural space. Pulmonary edema. Liver failure, so basically ascites causes third spacing, because technically it will go back up into the heart and cause more fluid retention. Lung cancer, kidney disease, so cirrhosis, again, liver failure as well. CKD, here, with fluid retention. Any fluid shifts. Signs and symptoms, you'll see shortness of breath, difficulty breathing, increased heart rate, increased respiratory rate, tachypnea, low oxygen, 89%. Just because someone has this pleural effusion and they have 89% doesn't mean they're good, because technically you don't know if it's from COPD or not. You'll see crackles, obviously you'll hear him. Edema, you'll see peripheral, you'll see that from heart failure, CKD, and cirrhosis. For pulmonary, you'll see that for heart failure. Orthopnea, so basically when you're lying down, it's hard for them to breathe. Low air entry, you'll see decreased air entry a lot for these people. Decreased breath sounds. It can happen if another side of the lung has a hemothorax. So let's say someone had blood in the lungs, that can actually third space and stuff and go into the pleural space, causing a pleural effusion. And that could look like, the output could technically look like more pinky, not as red, because of the pleural effusion. Another thing would be hydrothorax. So hydrothorax is almost the same thing as a pleural effusion. Clear fluid accumulates due to congestive heart failure. You'll see that from ascites, third spacing, liver failure. So you'll see edema, chest pain, low ejection fraction, fatigue, weakness, shortness of breath, impaired perfusion. You'll see them being confused, maybe having amber urine, because the fluid is not expelling from their body. You'll see maybe rare upper quadrant pain from liver failure, increased liver enzymes, low albumin. You'll see jaundice, ammonia, whatever. Renal failure, urine output is decreased, GFR is decreased, RAS and ADH increases edema. Fluid electrolyte imbalances, you'll see a lot of creatinine, a lot of bun, hypertension, portal hypertension, increases the preload, so more of a stretch on the heart. Signs and symptoms is dyspnea, difficulty breathing, shortness of breath, atelectasis, increased respirate, work of breathing, hypoxemia, so low circulation of oxygen in the blood, and chest pain. So basically, I should have mentioned earlier here as well, you'll see low albumin in their labs here for pleural effusion. You'll see high white blood cells if it's an ammonia. You got to give them antibiotics if that's so. Electrolyte imbalance, so make sure sodium and potassium is okay. For this person, increase ahead of bed, high Fowler is best. Oxygen, diuretics, fluid retention, depending on underlying cause. You need to treat it, so let's say if they have hyponatremia, or hypernatremia, then it's causing fluid shift, so be careful. Chest tube is inserted low because it's a fluid. Basically the same thing. Chest tube inserted low, suction, diuretics if it's chronic heart failure, congestive heart failure, increased head of bed, monitor to give oxygen to underlying cause. A hemothorax can be due to chest injury, vessel rupture, gunshot, cancer, clotting issues, internal puncture during CPR. Basically a lot of blood in the pleural space. You need a large bore because it's going to be below because it's fluid. You'll see signs and symptoms of chest pain, increased work of breathing, difficulty breathing because you're not getting enough perfusion and circulating oxygen, so hypoxemia. Decreased breath sounds for this person. Atelectasis, if you're not getting enough oxygen or there's so much blood that it's causing increased diffusion distance. Low cardiac output specifically, and increased heart rate. If the heart rate's 110, that's problems because your blood loss is more important than just fluid loss. Vitals, because of blood loss, you'll see low blood pressure, high heart rate, low oxygen because their RBCs are being taken out. Increased rest to actually kind of compensate. You see poor CWMS because you're losing blood. Hypovolemia would be part of this, so it's important to get chest tube inserted below, monitor vitals. Like we mentioned earlier, hemothorax could potentially cause a pleural effusion, so it could look like blood in the beginning, but after a few hours you can see like it become pinkish, so just keep an eye on it to see if it's like third spacing as well. You need maybe a blood transfusion, so look for cost match, pain management, monitor output, very important. In the beginning, it's okay to have a lot, but if it's a lot in later times, so that's a problem. Always check their vitals here. Administer IV fluids. Pleurisy is also known as pleuritis. It's basically when the pleura is inflamed, and this technically you don't need a chest tube for this because it's not like it's air, it's not like it's fluid, but it could lead to pleural effusion, which you would need a chest tube for. There's secondary to empyema, which is like the pus in the pleural space from infection. You'll see the membranes are rubbing against one another, and that's called a pleural rub, and it causes hella pain when deep breathing or coughing. So it's hard to encourage them to cough, to be honest, because it actually will hurt the shit out of them. It's because of the fact they don't have enough serous fluid in the pleural space that we talked about. It's due to infection like the empyema, autoimmune diseases affecting the lungs, so it could be a lot of different things here, cystic fibrosis or whatever, I don't know, to be honest. Lung cancer, trauma. Signs and symptoms would be chest pain, so with deep breathing and coughing, obviously unilateral, so only on one side, and it's very abrupt. You'll see shallow breathing with people that have pleuritis. Shallow breathing, pleuritis. Because it hurts the hell to breathe, like alveoli are not able to fully fill, and atelectasis. You'll see a lot of respirate high, Fever because of the empyema, increased heart respiration rate because empyema, and because you're having shallow breathing. For this person, you really want to give them NSAIDs because they have a lot of pain. So any analgesics, and it also helps to reduce the inflammation. Also, be aware if someone's getting NSAIDs, they should have good kidney function. Treat underlying cause, infection, antibiotic. Put them in high Fowler's blood work for infection, very important. Pleurisy can cause, or pleuritis can cause a pneumothorax. Can it? Pleuritis. I don't think so, actually. Forgot I said that. So, pneumothorax is differently just air. So, pneumo, air. You'll see bubbling in the water cell chamber secondary to the site to source, or due to pneumonia, or due to the pneumo, basically. Bubbling is normal. Too much, obviously not that great. But just keep an eye on it. And then you have to realize that titling is very normal with this through inhale and exhale. For this one, I wanted to mention again, if the titling is not that much, that's probably an indication of that they're re-expanded lungs already, so it's a good indication. So yeah, pneumothorax, you can get a spontaneous pneumothorax, affects tall, skinny guys, also people that have COPD. You'll see it's due to underlying lung disease, possibly like COPD, cystic fibrosis, TB. You get chest trauma, maybe medical procedures that maybe a ventilator causes a pneumothorax. There's also, let's say, like some people going into someone's vein can cause a pneumothorax. Any kind of procedures, a lot of procedures can cause a pneumothorax. You need a small bore, and it's going to be up in the chest because it's air. So you can also see subcutaneous emphysema, aka Rice Krispies. Air gets trapped in subcutaneous layer. Signs and symptoms, you'll see chest pain on one side, not as bad as, let's say, someone has pleuritis. Shortness of breath, increased respirate, decreased breath sounds, very, 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 because you see air related, right? A lot of them will see decreased breath sounds, to be honest. A lot of here, see, here, to upper lobes. So upper lobes means air. Lower lobes is for the other ones, I think, here. Yep. So cyanosis, because obviously it has to be dealing with an oxygen issue. Air. Fatigue, obviously for compensation, because they're really tired of having to breathe with so much effort. Asymmetrical chest movement, so one side not ventilating as properly as the other. Give oxygen. Chest tube insertion in the upper area, vitals, patient education, very important. No smoking during pneumonia, obviously. Avoid activities with pressure changes. Do a chest x-ray, a CT chest, semi-Fowlers. Semi-Fowlers is, I guess, fine. It doesn't have to be high Fowlers. Pain management, very important. Oxygen, very important for someone like this. Tension pneumo is when it gets hella bad. Pneumothorax could potentially become a tension pneumo if it is not resolved properly. A tension pneumo can also happen on its own. Let's say if someone like stabs someone, that could happen. Air deviates trachea away from the midline, basically. So pneumothorax is unhinged, basically. Causes trachea and mediastinum deviate, lowers the blood flow to the heart, which is really, really, really bad. So the aorta is compressed. Aorta is kinked. It can cause death. So you will definitely see someone having a hard time keeping themselves awake in the situation. The pleural space fills with hella air. The pressure is increased in the chest cavity because inhaled air not able to get out, and increases the respirate, increases pressure, and it's all due to the one-way flap, because you can't catch your breath. So one-way flap means like air can get in, but it's not getting out. The flap kind of just opens for air to come in, but it closes when the air needs to get out. Due to chest trauma, like we talked about, gunshot wound, stabbing, COPD. You can have a COPD-induced pneumothorax, but it's more so this pneumothorax than it is this one. Even if a chest tube comes out, potentially could cause a pneumothorax if there's too much air that goes in. Signs and symptoms is respiratory increase, shortness of breath, low oxygen, obviously, air related, low blood pressure because the aorta might be getting compressed, causing low cardiac output, causing hella problems, heart working hard because not enough and basically the normal anatomy is affected. Increased chest pain, asymmetrical chest, basically one side not moving with inspiration. With tension pneumothorax, let's say if it happened on the left side, then the right side of the trachea, it will deviate this way because all the pressure is going here, so it's pushing all the trachea and everything to the right side. So you'll see right tracheal shift for a left pneumo. It's all the opposite side always of where the actual problem of the tension is. If it's basically a left-sided tension pneumo, then the right-sided tracheal shift will be affected. Increased heart rate, obviously to compensate for the fact that you're not getting enough blood pressure because the cardiac output gets affected. Clinical signs of shock, you'll see someone that being pale, diaphoretic, increased heart rate, low blood pressure. If left untreated, JVD, you'll see that because the heart is trying to perfuse and maybe only one side of the heart is perfusing, so all of it's backing up. You'll see low breath sounds again for this person. For almost everyone, then you'll see low breath sounds. Decreased breath sounds. You'll see a chest tube inserted above in the air. Oxygen. You need needle decompression right away for this person. Call for help. Call a code if it's getting worse. You need a 3-way occlusive dressing for this person. Sterile water if a tube comes out. So basically, if a tube comes out, can call the tension pneumo, even if it started off as a hemothorax. A 3-way occlusive dressing, very important, so air can go in, but not in. So air can not go in, but it can go out. Any diagnostics for this type of person, for any type of pleural disorders, you will get chest X-ray. You see ABGs, get cultures to see if it's antibiotic related, an ultrasound, CT, MRI, angiography, radiography, BQ scans, so seeing ventilation perfusion scans to see air entry and exit, endoscopy, bronchoscopy to cleanse and gather obstruction or buildup, so from COPD, let's say. Thoracentesis, or let's say blood clots and stuff. Thoracentesis, so a needle going in and then pulling out, draining air and fluid. You also get a biopsy to see how the tissue health is. Pulmonary function test. Priority problems for pleural disorders are making sure the pain's managed, so let's say pleuresis. Knowledge deficit, so deep breathing and coughing. Anxiety, manage that because then you can actually compensate a lot more. You can have more problems. Ineffective coping, you'll see that with what's going on. Obviously, if you can't breathe properly, you're probably not going to do well. You're going to be like, oh my god, I panicked. Ineffective breathing pattern, obviously asymmetry of the chest. Activity intolerance because you get short of breath so quick. Impaired nutrition, and you'll see that someone's not able to eat or drink that much because obviously can't breathe. That's a priority. Impaired gas exchange, impaired perfusion, infection. Medical management, obviously treat underlying cause. Antibiotics, chest tube, small or large bore, depending if it is air or if it's fluid. Surgery, you might get a diplorectomy if it's collapsed. Pleural peritoneal shunt, so basically could potentially go into, I don't know exactly for this one. Decortication, so taking out lung tissue, potentially. Scraping out some yucky lung tissue. Pain management, analgesics, NSAID, obviously beware of nerve and also beware of liver for Tylenol. Nerve blocks, oxygen therapy. If you can't deep breathe and cough, it can lead to atelectasis. It could potentially cause you to be intubated or need mechanical ventilation.